There we go. Here's your video YouTube review for the respiratory system. What I've done here is I've combined all three PowerPoints into a single YouTube review. I've also eliminated many extraneous slides so we can focus on the critical information you need to know. Let's get to it. Respiratory zone. The really only organ that we're considering as the makeup of the respiratory zone are the alveoli in the lungs, which is where gas exchange takes place, or respiration. All the other anatomical structures of the respiratory system are part of what we would consider the conducting zone, whose purpose is to conduct air to the respiratory zone for gas exchange. You should know the sequence of anatomical structures that air moves through on its way to the respiratory zone. So one would be the nasal passages or nasal cavity. From there, air moves through the throat, and recall that you have three throats, so to speak. After the pharynx, the air moves through the area where you generate your voice, or the larynx. After that, it moves through your windpipe, which is called the trachea. And from the trachea, we move to the left and right bronchi, and then into smaller bronchioles. I'm going to call that 6. And from there into the alveoli of the lungs. Here, we're not going to get too crazy. I would say the knowing the difference about where the three throats lie here is potentially important. The nasopharynx would be in this area here. The oropharynx would be behind the mouth, roughly in this area here. And the laryngopharynx, just previous to the larynx, but not into the esophagus, would be in this area here. The other note here was on this sheet that we worked on in class. Many students made a mistake in where they indicated the trachea versus the larynx. Many students colored the trachea in much too far up, where you were into actually the larynx. How do I know where the larynx is? Look for the Adam's apple, otherwise known as the thyroid cartilage. The presence of this Adam's apple tells you that behind that is larynx, not trachea. So from this cartilage here, following back towards the cricoid cartilage in the back, this area here would be larynx, not trachea. And the trachea would be everything below it. Trachea would be down here. So look for the Adam's apple. Make sure you include the cartilage of the Adam's apple and the passageway behind it as part of your larynx, not your trachea. The three modifications made to air as it comes in is it's moistened or humidified, it's warmed, and the one that's left out here is filtered of foreign particles with the help of the cilia and mucus, which traps debris and infectious particles like bacteria. So warmed, moistened, and filtered. Here are your three throats. You should know them in order: NOL, nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is for air only, and the oro and laryngopharynx is a common passageway for food and air. Thus the need for the epiglottis. You should associate the larynx with your voice box and vocal cords. The Adam's apple, as I mentioned, is a good marker to to note the location of the larynx. And also the larynx marks the area that contains the epiglottis, which is a fold of tissue which closes over your windpipe to prevent food from going down it when you swallow. We noted that the epiglottis is a little bit different in its structure. It's made of elastic cartilage, which is softer than hyaline cartilages. Hyaline cartilage makes up most of the rest of the structures in this area. I left this slide in because I think you can see here in this lateral view, here's where your Adam's apple would be. Here's that thyroid cartilage. So you would say this marks the boundary of the larynx, and you can see below here, this would be the trachea. Once we move through the trachea and the bronchi and the bronchioles, we arrive at the alveoli. You have over 300 million of them. This allows for a great surface area for gas exchange between the air and your bloodstream. The alveoli are very thin, a single layer of simple squamous epithelial cells, which allows the O2 and the CO2 to switch places by diffusion. And if you recall, the gases move by their concentration gradients passively. Carbon dioxide moves out of the blood and into the lungs to be exhaled, and oxygen moves out of the lungs and into the blood to be delivered to your tissues. Pleura, you have two linings in your lung cavity, the parietal and visceral pleura. The parietal pleura is on the outside and lines the chest cavity wall. The visceral pleura is just inside of that and lines the external surface of the lung itself. In between these two linings is a small space in which there is fluid, which acts to reduce friction as your lungs inflate and deflate. These terms you should be familiar with. I noted there were some errors on the worksheet done in class on this slide. The intrapulmonary pressure, or pressure inside your lungs, versus the intrapleural pressure, or pressure in that cavity I mentioned that's in between the parietal and visceral pleura, and the atmospheric pressure are three areas which you should be able to differentiate what's going on in there. The atmospheric pressure simply is the pressure in the air outside, and that's constant. So everything is going to move in relation to the atmospheric pressure. The pressure inside the lungs, or the intrapulmonary pressure, is going to go up and down depending on whether you're inspiring or expiring. And this is due to movements in the diaphragm, which changes the volume of the cavity, etc., etc. So as the lung pressure changes, it will seek to equalize itself with the air pressure, or atmospheric pressure, and this is what moves air in and out of your lungs. So the pulmonary pressure, sometimes it's greater than atmospheric pressure, and this would cause you to exhale. Sometimes it's less than atmospheric pressure, and this would cause air to move into your body upon inspiration. The intrapleural pressure is always less. Always less. Less than what? It's less than everything. It's always less than the lung pressure and less than the atmospheric pressure. And this is important. It's going to keep your lungs partially inflated and prevent them from collapsing. That's illustrated also on this slide, this image. You can see here that the intrapleural pressure is lower than the intrapulmonary pressure. And again, that intrapulmonary pressure, listed here as equivalent to atmospheric pressure, will not stay that way. Again, as this diaphragm moves up and down, it's going to cause this volume to change, and it's going to change that pulmonary pressure. So how do we breathe in and out? As I've said, volume changes lead to pressure changes, which lead to the movement of air. In order to equalize pressure, again, we're moving according to concentration or pressure gradients here. Boyle's law, which you should know, is that as volume increases, the pressure of a gas goes down and vice versa. This text is fine. I thought summarized here in this diagram, maybe a little bit more simply, or at least more linearly here. So how does air move in upon inspiration? Your diaphragm moves down, your ribs move out and up. This causes the chest cavity to increase. As volume increases, according to Boyle's law, the pressure will decrease, and this pulls air into the lungs. You should know that sequence of events. And then expiration is the opposite. The diaphragm is going to move up upon relaxation. The rib cage will close. This decreases the volume. This causes the pressure to increase, according to Boyle's law, which causes air to move out of the lungs. This chart will be replicated for your quiz, and it will be blank, and you will fill it in. To me, I always start with the tidal volume. I think that's easy to understand and find and label. Tidal volume is the amount of air that moves in and out with normal breathing, not straining your lungs one way or another. This is equivalent to about 500 milliliters in an average adult male. You can obviously breathe out beyond the end of your tidal volume, and that's the expiratory reserve. You can also breathe in beyond the normal inspiration or top point of the tidal volume, and that's your inspiratory reserve. If you put these three volumes together, your inspiratory reserve, your tidal volume, and your expiratory reserve, you've got your vital capacity, otherwise known as VC, which is a good indicator of total air movement. So the amount of total air you are able to exchange from your lungs. There is a little more air left in the lungs which is not exchangeable. This is called a residual volume. And again, this is something that it's going to allow your lungs to maintain some partial inflation even when you breathe out, because you don't want your lungs completely deflated or collapsed, if you will. If you add this, the residual volume to the vital capacity, you get your total lung capacity, which I don't see listed here. So I will add it for you. It might have gotten cut off. So that would be all of this, your TLC. The two that I said you have to spend maybe a little bit more time on are the functional residual capacity and the inspiratory capacity. Those are subsets of some of these other things we talked about. What to remember for both the IC and the FRC is both of these start at the bottom of the tidal volume down here. So the functional residual capacity is the amount of air that's contained in the lungs after you breathe out on a normal tidal expiration. And the inspiratory capacity is the amount of air it's possible that you can pull into your lungs after a normal tidal expiration. Good luck with that. I said the two numbers here I'd like you to know are the average tidal volume, which is 500. Let's make that a different color. And the average TLC, which is 6,000 milliliters. I also might ask you to do some math and calculate one or the other of these, and giving you the rest of the variables. So bring your pencils, but not your calculators or phones or whatever it is you people use. These are reflexes. I wouldn't worry too much about them. Your breathing rate is controlled from your medulla and is about 12 to 18 breaths per minute. Changes in ventilation rate, hyperventilation or hypoventilation, are the result of too much or too little carbon dioxide in your blood. Hyperventilating flushes CO2 out of the blood, is what its primary purpose is. So if you have too much CO2, you're going to hyperventilate in response to that to get rid of it, to flush it out of your blood. Conversely, if your CO2 level is too low, you will hypoventilate to hold on to that CO2. If your blood is too acidic, which may include too much carbon dioxide or some of these other acids which build up, then you will also hyperventilate, again, to flush that out of your system. So if we think of CO2, if we can remember that CO2 is acidic, hyperventilating is going to get rid of that. We're near the end. Two diseases mentioned were emphysema and asthma. The term dyspnea, or breathlessness, or short of breath, is a common symptom of these diseases. As emphysema is usually due to smoking or other irritants inhaled long-term over the course of your life. Asthma can occur in almost anyone at any age, as you know, especially in younger people. It's also accompanied by dyspnea, but what distinguishes it is the inflammation that occurs in the bronchial tree in your respiratory tract, coupled with constriction of those spaces during an asthma attack. Fine. Have a good weekend. Good luck.